Last speaker before we go to Q&A session is David Whiteman, who works at the Queensland Institute of Medical Research here in Brisbane. And David's a medical epidemiologist with a special interest in the causes, diagnosis, prevention and treatment of skin cancer. So David's going to have a chat to us today about the latest in skin cancer prevention and early detection. Please welcome David.
Good morning, people, and it's a great privilege to be here at this event today, and I'm grateful to MPA and to the Cancer Council for inviting me. So I thought in my brief time here this morning I would share with you just some of the work that's been happening in the space of prevention and detection. You've had some excellent lead-in from Pip Ewell giving you the risk factors for melanomas and skin cancers. So I thought I'd share with you today just some of the thinking behind how these strategies might work. And just to let you know that I actually started out as a young doctor seeing patients, not very successfully, hence my move into research, but it was while I was doing that and seeing the constant stream of people coming in with preventable conditions. You know, most of the things that people turn up in hospital with could have been prevented if action had been taken earlier. And so I decided that in my career I'd try and do something to try and prevent diseases. And so I did my PhD with Adele Green, who is very well known in these parts as a skin cancer researcher, and so trying to follow in her path of cancer prevention, and particularly skin cancer. So as Pip has said, melanoma is a major problem. These are Queensland figures from 2007. Melanoma in our state here in Queensland is the second most commonly occurring cancer. You know, more than 2,500 people a year in Queensland diagnosed with melanoma. But when you put that on the same scale for the BCCs and SCCs, they absolutely, I've lost a thing there, they absolutely dwarf the number of patients with melanomas. About 100,000 Queenslanders a year diagnosed newly with BCCs and SCC. So that's about 3,000 people a day being diagnosed with, can't do the maths, but I think it's 3,000 people a day being diagnosed with BCC and SCC. And as Pip said, it's extremely costly. These are quite old data now from the Australian Institute of Health and Welfare, but they rank the amount of money we spend on treating cancers each year in Australia. So the numbers have changed a little bit over the intervening decade since these data were presented, but it would surprise most people, I think, that we spend as a country more on treating skin cancers, BCCs and SCCs, than on any other kind of cancer. That's a very sobering statistic. And dollars talk. I mean, we need to make sure that everyone is aware that this is a cost to our country that I think you'll agree is largely preventable. So just a little bit about the theory of how we control these types of diseases, and I've got some jargon terms here, but if you look at, you think of someone's lifespan as, you know, beginning at the moment they're born until the moment we die, at some point a person may develop a melanoma. And it might be a space of several years until that melanoma actually comes to attention and is diagnosed by a doctor. And so in the field of public health, we sort of break up our cancer control strategies into those things that try and prevent the cancer from ever occurring in the first place. We call that primary prevention. To do that, you've got to know what causes the disease and then try and reduce people being exposed to those causes. Secondary prevention is about bringing forward this time of diagnosis as early as possible, making this interval as short as possible so you can pick up the cancer while it's still very, very treatable and thereby improve survival. And then we talk about tertiary prevention, which is postponing death from a cancer. So we'd like anyone diagnosed with a melanoma to live with the disease rather than die from it. And so tertiary prevention is the term we use to postpone death. So that's the sort of talk that we're focusing on today: primary prevention and secondary prevention or detection. As Pip has outlined for you, the causes of skin cancer are numerous. Some of them are modifiable and some are not. So Pip has outlined to you the factors of the host, the person, that contribute to an increased risk of cancer, and she's explained those very clearly. And then there are the environmental factors. Principal amongst those is UV radiation, sunlight. The major cause, without question. But there are other factors that we are exposed to that can increase or decrease your risk. So there's quite a lot of evidence now that people who have transplants and are on immunosuppressive medication to allow the organs to stay in the body, those people have decreased immunity, and that it correspondingly massively increases their risk, particularly of the SCC kind of skin cancer. So medications can influence your risk. There's also emerging evidence, in fact, that aspirin and non-steroidal anti-inflammatory drugs can decrease your risk of skin cancers. Now, I'm not advocating that anyone goes out and self-medicates. That would be the wrong advice to give you until we understand whether that's true or not, until we understand what the risks are. But it's just to let you know that there are other things that might come through that would act to decrease your risk of cancer. And there's always a lot of interest in the role of diet as well. So a lot of research into whether antioxidants and particular dietary components decrease your risk of skin cancer. Most of those trials have been sadly negative, so we don't have good evidence that diet influences your risk, although many people believe that, but the evidence for it is lacking. So the main thing that we can focus on if we're talking about primary prevention is really focusing on reducing our exposure to sunlight. And that's where all of the efforts really have gone in this space. So the question is, well, does anything work? It's one thing to know that sunlight causes skin cancer. It's quite another thing to be able to show that reducing your exposure to the sun actually leads to a decreased risk. But there is actually a lot of evidence that decreasing your exposure to sunlight works. So there are strategies that affect you as an individual person, and these have been summarised by a very large scientific body called the US Preventive Services Task Force. They publish their stuff online. It's all downloadable. It's also published in these eminent medical journals, and this is just one of those publications. And then there are community-based interventions, so things where we use shade screens and things in the community. And again, some of those things have been shown in trials to actually work. So there are a lot of strategies, and I'll just briefly summarise some of those. This is the summary document from the US Preventive Services Task Force. NHMRC in Australia does a similar process. But basically, these are the 5 things that are recommended for which there is evidence of a positive effect. Using broad-spectrum sunscreen, wearing hats, wearing sun protective clothing, avoid outdoor exposure, and avoid indoor tanning. And I would hope that none of this is new to anyone in the room. Every Queenslander should know this. It should be burned into the brain. But it's just to let you know there is data, scientific data supporting these statements. In terms of the community-based interventions, the US Centers for Disease Control in Atlanta produced this summary document. And so they've shown that there is evidence from trials around the world that interventions in educational settings work to reduce sun exposure. So that is, there's evidence from childcare centres, kindergartens and daycare as we have in Australia, evidence from primary schools, evidence in secondary schools, and outdoor occupations, and Melanoma Patients Australia has been a leader in that area. Interestingly, there is insufficient evidence yet that doctors telling people to stop going out in the sun is actually working. So we have to leave it to our colleagues in other settings to take the lead on that. Not to say that it doesn't work, but just the studies have not been very conclusive yet. Mass media, interestingly, does not yet have evidence behind it to show that if you bombard people with advertisements, it leads to an effect. But again, I think as the messages become more targeted, I think we'll see an effect. And the strongest suggestion was that multi-component community-wide interventions work. So that's very heavy jargon, but it means the sorts of strategies that the Cancer Council is operating, the SunSmart strategy, where you target legislation and regulation to make sure that there is shade in new design buildings, that you increase awareness in the population, that you remove taxation on sunscreen products. So multiple levers that you try and pull all at once to influence population behaviour. And so this is an example of some stuff that's happening in the mass media. Now this is actually Danish advertising. And the logo down here, or the motto, is "Your skin never forgets." And they call this the Elephant Skin Campaign. And they're trying to impress upon impressionable teenagers that using sunbeds and going out in the sun has long-lasting effects on your skin. And in fact, this is one of the new wave of advertising that has been heavily road-tested before it got released. And the Danes have shown that this has had a massive impression on Danish youth. And in fact, before they released that series of advertisements, they piloted a whole lot of other advertising styles trying to show the dangers of sunbeds. But these flopped. When they did focus groups amongst the young people, they were thinking, am I going to get eaten by something, or am I going to get squashed, or what's with the shark? So it seemed like a good idea on paper, but when you actually road test it, it doesn't work. So the importance of scientifically appraising your interventions is crucial, and so we're learning that as we go along. I won't summarise all of this slide, but a key question that keeps coming up is, well, we can put all this effort into educating people, we can put all this effort into putting on sunscreen, costs money, and it might just be cheaper to wait for the skin cancers to come up and cut them out. And there are certainly some people who argue that, but unfortunately for them, they've been proven wrong. So quite a number of studies are emerging, and it's an area of health economic research, and I can't defend these figures, but basically it's been shown time and again that skin cancer prevention interventions work out to be cost effective. You're better off investing in prevention than waiting for the cancers to come and then having the costs of treatment. So that's quite a strongly identified message. And probably the best evidence for that comes from data right here in Queensland, led by Adele Green and conducted by Louisa Gordon. They did a very, very nice trial in the town of Nambour. 1,000 people were randomised to receive sunscreen and apply it every single day. The other 1,000 people were told just do what you normally do. Followed them up for 5 years and showed a halving in the incidence of skin cancer in the sunscreen group. But that intervention costs money. You've got to pay for the sunscreen, you've got to pay for doctor visits, you've got to pay for time off work, you've got to pay for parking to go and get your skin checked, you've got to pay for misdiagnoses. They added all of that up and found that the cost to the society of implementing that intervention was $1.03 per day for everybody in society to prevent one skin cancer. So their conclusion was that if health providers, governments and individuals were collectively willing to pay and contribute to preventing skin cancer, this initiative would save a lot of money over a 5-year period, or $1.03 annually per person. So I think these are the kinds of arguments that persuade politicians and persuade other people that it's actually a cheap intervention to save the occurrence of skin cancer. And this is exactly the same slide that Pip showed, so I won't speak to it too much, but as she said, this shows people of the same age who were born in different eras, in 5-year eras. Here are the oldest people, the people in their 80s. You can see those born back in the 1890s had lower rates than those who were born in the 1910s. And the same patterns are seen all the way through until you get down to these younger people here. And these people, this is the age when the SunSmart campaigns first started. So these are the beneficiaries of those campaigns, because as we know, most of the damage that leads to skin cancer occurs in early life. So for these people, the horse had bolted when the SunSmart campaign started. For these younger people, they can benefit. So as these people move into these older age groups, we will hope that all these curves start to turn downwards, and that's what we're going to monitor very closely in the years ahead. And just to show you as well that previous slide was for melanoma, but we're starting to see a decline in treatments for SCCs and BCCs in younger people. So these graphs here show for men and for women the rates at which Medicare expenses have gone up for treating skin cancer. So in these older age groups, the rates are still rising rapidly. So unfortunately for most people in this room, that's where we find ourselves. But for the younger people in the Australian population, the rates of skin cancer treatments are actually declining, and declining quite rapidly. And you might say, well, maybe they're just too scared to go to the doctor and they're not having their skin cancers cut out. But in fact, when we look at them being treated for cryotherapy and other things, the rates are much lower in those people as well. So they're not just avoiding going to the doctor. And in fact, we've got even stronger evidence of that. When we look at the rates of biopsies, the number of biopsies are still going up. So people are still going to their doctor with concerns, but they're not finding skin cancer, which is a really good thing. So I'm just going to close out now with a couple of quick slides on secondary prevention. Secondary prevention or screening can be done in different ways. So you'll be familiar, I'm sure, that we have breast cancer screening in Australia, we have the pap smear screening, we now have bowel cancer screening, but we don't have skin cancer screening as a formal process. And the reasons for that are many. It's very expensive to do. They'd find an awful lot of cancers, and there's a concern about costs. So we have these other options of selectively screening people who are at high risk, or we can just do, which is really what's happening now, people self-select to attend their doctor and say, can you check my skin, please? And that's really where we are in Australia, which is the sort of third best option overall, but that's what's happening. And that's because quite a number of bodies have looked into this very closely, and the issues are complex, and I can't go into all of them today, but there is no recommendation that mass or population screening for melanoma or non-melanoma skin cancer works, but they do recommend that high-risk patients are screened. So into this space now, we now have the challenge, okay, well, that's the advice, you've got to look for high-risk patients, but who's at high risk? And so a lot of research is now going into trying to find those people before they get a skin cancer who are at higher risk so that they might go to their doctor and be picked up. And so that's an area of research that I'm heavily involved in. We've just started a big study called the Q-Skin study, and our aims are to try and, for these particular cancers, define the pathways, but most particularly look at risks and risk prediction. So we've enrolled, we invited 200,000 people. We've now got 45,000 people in this study, and we're following them up through Medicare. So as time goes on, we're going to be building very precise risk prediction tools that we'll be able to give to GPs and to their patients, so people can identify for themselves where they sit on the spectrum of risk. And the plan is to build these sort of risk prediction charts. And some of you may have seen charts like this for patients with diabetes or heart disease, but GPs use these sorts of charts regularly. You know, if it's for heart disease, they say, well, what's your blood pressure? Do you smoke? How much do you weigh? What's your family history? And they can very quickly put you in a category and say, right, we need to monitor you. And so we want to do exactly the same thing for melanoma and skin cancer. And so I'm just going to close out by saying it's a contentious area sometimes. I was living in the UK about 15 years ago, and these were the headlines in the middle of summer one day, and it was a nice English summer actually, and out came this headline saying that sunbathing is healthy, and this was the first of the vitamin D reports starting to come through the literature. And this does have an effect on people's behaviour. And the next day I went to the Henley Regatta, and there are these poms sitting out in the sun, pointing due south and just absorbing the sun. Now, that may not be such a risky activity in England, but if you did that in Brisbane, we all know what would happen if you spent the day out like that. And so these mixed messages are something we're going to have to manage, and it's a difficult area. So in closing, my advice is to heed the advice of the Cancer Council and keep up the good work. Thanks very much.